Today we're going to talk about nutrition support in short bowel syndrome. I do have one disclosure. I am a speaker for Fresenius Kabi. Objectives today, we're going to define short bowel syndrome, discuss the different types of nutrition support in short bowel syndrome, discuss fluid management, and then describe the roles of certain medications relative to short bowel. So the definition of short bowel syndrome. Short bowel syndrome results from surgical resection, congenital defect, or disease-associated loss of absorption and is characterized by the inability to maintain protein, energy, fluid, electrolyte, or micronutrient balances when on a conventionally accepted normal diet. You may also see it defined as adults having less than 200 centimeters of residual small bowel after resection, and pediatrics having small bowel less than 25 centimeters in the presence of an ileocecal valve, or less than 40 centimeters without their ileocecal valve. The pediatric incidence, the true incidence of short bowel syndrome and intestinal failure in the US is unknown because of, in part, the lack of precise definitions, but we do know that short bowel syndrome occurs in 24.5 out of 100,000 live births. The fatality estimates have been cited as high as 50% in these patients, and it accounts for 1.4% of deaths in children less than 4 years old. Morbidity and mortality of pediatric short bowel is primarily related to the development of end-stage parenteral nutrition-associated liver disease. And we'll touch on that later on. So pediatric etiology, you're going to have two different, you're going to have surgical and functional. You can see listed here some of the surgical causes would be gastroschisis, midgut volvulus, intestinal atresia, neck, which is what we see a lot, and vascular traumas or thromboses. Your functional etiologies for the pediatric patients are going to be their disorders of motility, chronic pseudo-obstruction, and Hirschsprung's are two of the ones you see in that category, and then secretory disorders. So those are going to be your microvillus inclusion disease, and then your protracted diarrhea of an unknown cause. Adult etiology, you're going to have some of the same as pediatrics, but you're also going to see an adult short bowel syndrome is caused by massive surgical resections, Crohn's disease, malignancy, radiation enteritis, trauma, again, vascular issues, volvulus can be seen in adults, hernias, small bowel fistulas, as well as gastric bypass patients, post-gastric bypass, and then chronic pseudo-obstruction. So your gastrointestinal tract, why do we need it? So as we know, the absorptive capacity of the intestine is a function of multiple variables. So it's going to depend on your surface area, your digestion and metabolism, motility, perfusion, and microflora. And the capacity of the intestine is designed to assimilate the dietary load to meet energy requirements for growth and metabolism. And this slide here, I know it's kind of hard to see. Y'all might be able to see it bigger on the big screen, but I know on the slides it's hard. This is just a picture of our entire small bowel. The next couple slides after this will look specifically at all the parts of the small bowel and why we need them for what nutrients to absorb, and then what are the complications after resection. So our stomach is an important as an intrinsic factor. Is produced there and binds to B12 for absorption later in the ilium. Your duodenum, this is going to be where your absorption of carbohydrates, fat, and protein occur. It's the shortest segment of the small intestine. You're also going to have some micronutrient absorption, which is going to include iron, calcium, phosphorus, magnesium, and folic acid. Complications of resection when you remove the duodenum are going to be decreased micronutrient digestion, anemia, you can see acidosis, and then osteopenia. The jejunum, this is about 2/5 of the small intestine. This is going to be your primary site of protein and carbohydrate, as well as you'll have some fat absorption. You'll also have absorption of calcium, zinc, and water-soluble vitamins. When this is resected, some of the complications that can occur are going to be decreased disaccharide activity, which leads to carbohydrate malabsorption. And this is where you see osmotic diarrhea in patients with short bowel syndrome that have this removed. And then you'll also have fluid and electrolyte losses. The ilium, this is going to be the distal 3/5 of the small intestine. Foods move slower through the ilium, and this is the last stop for your digestion in the small intestine. So this is the site primarily of B12 absorption. You also have bile salt reabsorption, about 95%, to assist in fat absorption, as well as fat soluble vitamin absorption occurs here. This adapts better than the jejunum after resection. Complications of resection include the inability to absorb B12, increased risk of renal oxalate stones, fluid and electrolyte malabsorption, and then insufficient absorption of bile acids, which can lead to long chain fat and fat soluble vitamins being malabsorbed. Your ileocecal valve. You hear this a lot, like we stated in the definition. When you're looking at patients with short bowel and their length, you're going to determine if they have their ileocecal valve or if they don't have their ileocecal valve. And this is because the ileocecal valve slows transit time. Micronutrient malabsorption is going to occur with a fast transit. So if you don't have this, you will see an increase in the transit time. And it's also a barrier to bacteria moving from the colon to the small intestine, which we'll touch on later what can happen if that occurs. Complications with this resection of the ileocecal valve are going to be bacterial overgrowth and then rapid transit time. In your colon, this is needed for fluid absorption, as well as the reabsorption of sodium, chloride, potassium, and fatty acids. Complications of resection for this is going to include dehydration in your patients, electrolyte abnormalities, and then it also reduces the ability to absorb bile salt. So that being said, looking at all the different parts of the bowel, can the bowel adapt? It depends on several factors. It depends on the length, the type, and the condition of the residual bowel that is left. Is there surgical narrowing or change in the bowel that's left, and poor perfusion? Again, the presence or absence of the ileocecal valve will also determine if the bowel is going to be able to adapt, and then intestinal motility. Functional improvement for this can take up to 2 years, so it's not going to be immediate. And during the first 6 months after surgery, you might see a period of gastric hypersecretion that usually occurs. Other changes are going to include mucosal hyperplasia, increased mucosal blood flow, and then include segmental absorption. So what are the initial determinants of intestinal function? So the main determinant is going to be the initial phase right after your intestinal resection. So the length of the intestinal resection relative to their age or body size. Again, it's dependent on you have an adult or pediatric and how much of that is removed. Again, the loss of the ilium and the ileocecal valve, the loss of all or part of the colon, and then continuity versus continuity of the intestine. So there's 3 categories of bowel anatomy. The next couple slides have a lot of information on it. So I'm just going to highlight some important things on them, but the 3 categories of bowel anatomy after resection are typically described in terms of the location of anastomosis and implications for prognosis. So you have the jejunocolic anastomosis. This is going to result after the entire ilium, ileocecal valve, part of the colon, and variable amounts of the jejunum are removed. This is the most common anatomy in short bowel syndrome with prognosis that depends on the length, again, of the remaining jejunum. You have a jejuno-ileocolonic anastomosis. This is going to result after a portion of the ilium with retention of the ileocecal valve in the entire colon. So this category usually is going to have the best prognosis after resection. And then finally, you're in jejunostomy. This is going to result after the entire ilium and colon, or colon present that's been left, but disconnected. And this generally you don't want. These are generally the patients that unfortunately come from the rehab side to us on the transplant side. So when is nutritional autonomy at risk? Again, when you see the jejunal-ileal anastomosis with less than 35 centimeters of residual jejunum left, and also jejunal-colonic anastomosis with less than 60 centimeters of residual jejunum left, and then finally having an jejunostomy with less than 135 or 115 centimeters of residual jejunum. A jejunal resection of about 50 to 60% is usually well tolerated in patients, but greater than 30% of ileal resection is going to be poorly tolerated in these patients. And then severe malabsorption usually occurs when there's small bowel less than 60 centimeters total. I know this is a lot of numbers and anastomosis, and if you don't work in this, but when you start working with small bowel patients, you start learning the different terms of anastomosis. The lengths are the biggest thing that you pay attention to when they come to you for their nutrition assessment. So what are the surgical options for short bowel syndrome? Some patients do require surgical intervention in addition to medical management. So this is a slide that shows some of the approaches for the different patient groups. So if you have a patient with adequate remnant bowel, adequate length with dilated bowel, the operative approach is going to be just to relieve the obstruction if there's one present, and then possibly bowel tapering. If you have a patient with short remnant length with dilated bowel, their operative approach is going to be intestinal lengthening. And then if you have a patient with short remnant length that's on parenteral nutrition, suffering complications, most likely this patient is going to end up needing an intestinal transplant. So since we talked about some of the surgical approaches, I'm just going to go over them very briefly since y'all want to hear the nutrition and not the surgical approaches. But these are some of the common ones you're going to see in your short bowel patients. Your tapering and neuroplasty. So this does not gain length. It is easy to perform, but you're going to lose absorptive surface, which is what you want when you are performing some of this stuff, trying to save the bowel. It does reduce the luminal diameter. So the next two procedures are bowel lengthening procedures. This is what you'll see a lot of. First, you'll see the step procedure. So this is when rows of alternating slits or V-shaped cuts are done in the small intestine with the idea of this allows for lengthening of the bowel. So you can see before pre-lengthening and then with the post-lengthening, you kind of have like a zigzag shape. So they're getting more absorptive area. The goal for this procedure is to increase the length, to tolerate nutrition, and to promote enteral nutrition. The Bianchi procedure, this divides the bowel in half, and then one end is sewn to the other. Again, lengthening the bowel, hoping to give more absorptive capacity. And it's important to know that a step after a Bianchi can be done, but you cannot do a Bianchi procedure after a step. And working in short bowel, you have patients that come from all over and they might have been stepped 2 or 3 times, or they might have had a Bianchi. And again, the goal with these are to be able to lengthen the bowel to get more absorptive area and hopefully get these kids or adults off of parenteral nutrition and onto oral diet or enteral. So what are some of the complications that we see related to short bowel syndrome? Nutrient malabsorption, like we talked about, primarily carbohydrate and fat loss. You're going to see your vitamin malabsorption, B12 and fat-soluble vitamins. Oral aversion, this is seen a lot in the pediatric kids. They've never eaten before, so they've been either too fed or on parenteral nutrition, so they don't know what it's like to eat. Growth problems for our pediatrics when it comes to length for height. This is also seen in the adults. We have a lot of adults that will come to us on short bowel that are severely malnourished. So it's not just, you say growth problems for kids, but you're also seeing adults come in underweight. Parental nutrition induced liver disease or failure. This is one of the most common complications that people see and kind of freak people out when it comes to short bowel syndrome. And how can it be reversed or fixed or even prevented? You'll also see large fecal output. So with this large fecal output, you're going to have a loss of sodium and zinc, which is going to lead to failure to thrive in your pediatrics, but also your adult patients. And then catheter infections and sepsis. This is something that unfortunately is seen a lot because a lot of these kids and adults are dependent on parenteral nutrition or IV fluids. So making sure that line care is being done and done properly. So earlier I did highlight small intestine bacterial overgrowth, SIBO, which is what it's abbreviated as. This is a complication that is a disorder of excessive bacteria in the small bowel. So your causes are going to be any condition that interferes with muscular activity of the bowel. Any abnormal connections between the bowel and the colon can cause the bacteria to move backwards. So again, that's why it's important to know if your patient has their ileocecal valve or not. Diagnosis for this is done by a lactulose breath test. Symptoms for this can include nausea, bloating, and chronic diarrhea. And the consequences of SIBO are the bacteria deconjugate bile salts, which leads to decreased absorption of fat and fat-soluble vitamins, as well as decreased B12 absorption. Your treatment for this is going to be antibiotics and lactate-producing probiotics. So overgrowth, there was a study that was done. So in addition to just the nausea, bloating, and chronic diarrhea, you can see the patients that they'll develop abdominal discomfort. You'll see their abdomen distended, or they complain like it just hurts and there's something in there, which then causes them to lose weight because they're not eating. So it is important that if these signs and symptoms occur and that you know that they don't have an ileocecal valve, that you do this lactulose breath test, because things can be done to treat this. And treatment, typically with the antibiotics, after one round can be treated, but if it doesn't and it continues to occur, you'll see them on cyclic antibiotic treatment. So they'll be on for a short period of time, they'll take a break, and then they'll put them back on. So what are your nutrition goals with your short bowel syndrome patients? The first one is obviously intestinal adaptation, because without that, can't really go anywhere. You want to eliminate parenteral nutrition. That's the number one thing that we want all these patients off is their PN, but also to avoid overfeeding them. Transition to enteral or oral nutrition is going to be your goal. So by doing that, doing oral stimulation for anyone with an oral aversion. You also want to stimulate adaptation. So this is going to be direct contact and absorption of nutrients by enterocytes, and stimulation of pancreatic and bile secretions, trophic hormones, and growth factors in the bowel. And then with your pediatric patients, again, achieving adequate growth and development. Mother nutrition goals for these patients is going to be appropriate PN management, which we'll discuss in a few slides later down the road with how to do so. Adjustment and increase of enteral nutrition. This is something that if you see it working, continue to increase. Don't be afraid, because again, we want to get them off parenteral nutrition and onto enteral nutrition. Maintaining and monitoring vitamin and mineral status. The prevalence of deficiencies increased during the transition from parenteral to enteral. So you might not necessarily see any deficiencies right away when you're switching them from parenteral to enteral, but a couple of months down the road, whether it's 3 months or 6 months, you might start seeing those deficiencies occur as they're weaned from parenteral nutrition. Again, oral stimulation, especially in our kids that do have oral aversion, that have never had anything by mouth. So your nutrition assessment, it's pretty straightforward with some exceptions. You want to plot their anthropometrics, so their weight, length for height, BMI, and head circumference. For the pediatrics, for your adults, you're gonna plot their weight for height and their BMI. Determine their macro and micro requirements. So this is important when it comes to whether they're on parenteral nutrition fully dependent or if you're transitioning them to enteral, making sure that they're getting not just macro needs, but getting their micro needs. So this will come in with evaluating their lab work. Patients with short bowel are at risk for vitamin and micronutrient deficiencies, even after they achieve their enteral autonomy. And at the end, I have a slide that goes over when to check their vitamins and minerals, but just knowing that you still have to remember the micronutrient requirements and you still need to periodically check them. A physical exam of the patient, again, oral feeding history. This is going to be primarily for your pediatrics, but it's also going to be for your adults too. You want to see what they were eating, how much prior to resection, how much they're attempting to eat after. They might all think they can eat after, but then when you see their outputs, they probably shouldn't be eating after. Parenteral and enteral nutrition history. So what parenteral regimens they've been on. With their enteral history, what products have they tried? Because usually these patients will come in and I don't want to say desperate, but they might seem desperate and they've tried a lot of different formulas enterally just to find one that works and that they can tolerate. So just finding out which ones they have already been on. Their surgical history, as we looked at the importance of that earlier in the slides, and then their output history. So for these patients, it's going to include a lot. It's going to include their stooling, their emesis, their ostomy output if they have an ostomy, and then miscellaneous drains. A lot of these patients will come in with tubes all over the place. So they don't just have an ostomy, they don't just have a feeding tube, they might have fistulas, they might have pancreatic drains, they might have biliary drains. So just taking into account every drain that they have and how much output it has. Lab monitoring for these patients initially and frequently as you're following them, you're going to want to get a Chem7, you're going to want to check their calcium, phosphorus, magnesium, triglycerides, their liver function tests, CBCs, vitamins A, D, E, and K, as we talked about, the fat soluble vitamins and depending on what was resected, zinc, an iron panel, and then vitamin B12. So there's a lot initially to check, but then as you continue to follow these patients, these are the same labs you want to continue to be checking with them as you wean them from parenteral nutrition to enteral and oral. Stool studies can also be done if the patient's showing signs of feeding intolerance or having increased stooling. This is something you might want to do, and there's an array of different tests that can be done. So right here is just listed some of the common tests that could be done if the patient does require stool studies for our patients. Most of them do have feeding intolerance when they come to us, and they do have a lot of stool, and that's their complaint. So we will do stool studies on them. So this chart right here is your general nutrition care pathway. It's kind of just like the guideline of what to do and how should you feed the patient. I'm not going to go on and read every single thing, but obviously if you do the assessment, you see if they're a candidate for nutrition support if they need it, and if there's contraindications to enteral nutrition. If there's not contraindications to enteral, you'll want to start enteral nutrition. And then again, that's going to be where you're going to look at their GI function and what's been removed, what kind of ostomy they have, what kind of feeding tube they have, and then decide which kind of formula you want to use. If there are contraindications to enteral nutrition, this is going to be your patients with intestinal obstruction, ileus, peritonitis, bowel ischemia, vomiting and diarrhea that's intractable. This is when you're going to start the parenteral nutrition as their nutrition pathway, and then as you start to learn them and fix things and work with medications and stuff, then start transitioning them to enteral. So enteral nutrition, you want this in order to promote adaptation and prevent intestinal atrophy. Enteral feeds are started as soon as possible after intestinal resection. You don't want to wait. You don't, if you can start, even if it's a trickle feed, you want to be able to start it rather than giving the bowel so much time on it. For patients with an ostomy, their goal output is going to be around 30 to 40 mLs per kilo per day. And it's important to note that due to the malabsorption that these patients have after resection, their EN needs may be up to 150% of the DRI. So you're feeding these kids and these adults a lot more than typical. So you might see like, oh my gosh, they're the amount of calories they're getting per kilo, but you have to remember if they've lost their absorptive capacity, they're not absorbing everything, that you need to give them more than they typically require. And this goes for the adults and the pediatrics. When choosing enteral formulas, obviously for pediatrics, human milk is best. If you can use that, that's what you want to use. But unfortunately, that's not always the case, and we can't use that. So then we have to look at alternatives for that. So the two main types that you'll see are the partially hydrolyzed formulas. And these are going to be your proteins that are partially broken down. These are going to be peptide-based proteins. So these are going to be ones that are suitable for your malabsorption, maldigestion, and other GI conditions. It's a little easier on the bowel than giving them a standard formula. And these can be started at age 1 and go all the way up. The other types of formula that you'll see are the fully hydrolyzed formulas. These are going to be your proteins that are completely broken down. They're also hypoallergenic. So these are going to be used for your patients that might need low fat, fully hydrolyzed. They're used in severe short bowel patients, severe fat and protein malabsorption. And then these usually are what the patient's post-intestinal and multivisceral transplant will be started on before they transition off. These formulas are suitable for infants that can't tolerate intact or hydrolyzed protein, that have protein malabsorption, that also have severe food allergies as well, or any kind of other GI tract impairment. So how do you advance? You have a patient, you have them on enteral nutrition, you've decided on your formula. Now let's see if they can tolerate it, which is always the big question that we always want to know. These are going to be done in much smaller incremental changes than your standard patients on a tube feed. Kind of have to baby them without babying them too much, but it's also going to depend on the patient's anatomy, their tolerance, and what their future goal is. And for these patients that once you're able to start them on an enteral product, you want to start their speech referral as soon as possible. Even if they don't eat, even if they show you zero interest in wanting anything by mouth, it's better to start it early, knowing that you're starting their enteral, because again, your hopes are going to be that they come off the enteral and then they can take a PO diet. If the patient's rehabable, you can do a continuous drip, which is going to start with a trickle feed. And these are just some of the guidelines and some of the ways that we do it. Each institution kind of has their own protocol per se of how they advance. But with our patients, if we know we're going to go down the rehab route of these short bowel patients, we'll start them with a trickle feed, and then we'll advance 2 times weekly. Some of them are also, when they're started on an intermittent bolus, we're going to start at a lower volume and then attempt to advance 1 to 2 times a week, depending on how they tolerate. And we typically give this bolus over 1 to 2 hours. And the older the kid is, the easier it is to advance volume-wise. Obviously, the smaller babies, you're not going to be able to advance as much as fast, but the older kids and the older adults, you can advance these boluses faster. And unfortunately, if they're not rehabable or if rehab fails, you want to just focus on the PO for pleasure, just to build the autonomy to eating, but also prevent, again, future oral aversions down the road. So now to talk about parental nutrition in these patients. First, we're going to look at pediatrics, then we'll look at adults. With your pediatric patients, you want to meet the protein needs, but also note that their protein needs for these patients are going to be higher than expected for age due to their losses. So they're not going to be your typical, they might not be 2 grams per kilo. They might need upwards of 2.5 grams per kilo, just depending on what their GI losses are. Infants who are PN dependent can require up to 4 grams per kilo per day, while the older children might require 2 to 3 grams per kilo per day when they're fully PN dependent. Dextrose, you want to deliver, you want it to be 40 to 50% of their total calories, maintaining a GIR of less than 12. And then their lipids, you want it to be 30 to 40% of total calories. And it's important to note that with these patients, when you're deciding their overall calories, it's going to be dependent on, are they exclusively PN dependent, or are they also enterally fed? So you might not necessarily be giving them 100% of calories from parenteral nutrition. So where is that line of, you can meet their enteral needs knowing that they need more, but you also need to make sure that you're meeting their parenteral needs in the meantime until you can get to their goal enterally. So your parenteral nutrition for your adult small bowel patients, again, they're going to require higher protein amounts because of their losses. So they're going to range anywhere from 1 to 2 grams per kilo or even higher. We've had patients that have needed 2.5 grams per kilo of protein, but as long as you're monitoring their labs and looking at the whole picture every week, or when you see them in clinic, just know that they do require higher amounts of protein. Dextrose, again, is going to be 40 to 50% of their calories, maintaining a GIR less than 7. And then lipids, again, are going to make up 30 to 40% of their total calories. So I wanted to take some time over the next couple of slides to talk about the lipid injectable emulsions and the different products that are out there and available for your short bowel syndrome patients, because a lot of times this is when they come to you and they're like, their liver's failing, or they're not tolerating the parenteral nutrition, their LFTs are high. But it's very important to know that the lipids aren't bad. These patients are dependent on them, especially the babies and the kids, where you are trying to promote growth. So just making sure that when you do have a short bowel syndrome patient on parenteral nutrition, that no, there are options for lipids, and there's different ones you can try to reverse the PNAC or to try to make it not as severe. So the first one that we're all probably most familiar with is your soybean oil lipid emulsion. This is going to provide calories. So you're going to get 10 calories per gram. This is going to provide your essential fatty acids, and you'll see this used as the treatment for essential fatty acid deficiency. This lipid can be used both in your adult and your pediatric patients. Your contraindications for this is going to be allergy to soybean, egg, or any of the other active ingredients, and then triglycerides over 1,000. Potential use for this, you'll see this used as like a short-term lipid with your patients that may just need parenteral nutrition for a couple weeks because they're tolerating EN, but they just might need some extra calories. So they're only using this, they only might need 4 weeks of parenteral nutrition. So sometimes you'll see this knowing that they're coming off of it. Normal liver function test is when you would use this lipid. Again, the treatment of essential fatty acid deficiency, and the dosing for this, which we'll discuss on the next slide, it does meet your essential fatty acid needs. So here you can see the dosing for neonates all the way to adults. So I've included the initial dose and then the maximum dose of what you can go to. So you can see it's broken down, and it's important to note that it's by different age ranges. So you have your neonates to 2 years, 2 to 12 years old, 12 to 17, and then your adults. With this, you want to dose for the first 15 to 30 minutes and then gradually increase to their required rate after 30 minutes so you can get them to that goal dose. And then I've also included the lipid infusion rate, because this is something that's asked amongst all lipids, and no matter what lipid you're doing. It does have some changes now. It's read as 0.75 mLs per kilo per hour, but that's the same as what it used to be. Is for anyone less than 17 years old, it's 0.15 grams per kilo per hour. And the adults are going to be, it's again, 0.5 ml per kilo per hour. So your next lipid choice for these patients that come to you on PN is going to be your 4-oil lipid emulsion. This is going to contain 30% soybean oil, 30% MCT, 25% olive oil, and 15% fish oil. This is a source of calories and essential fatty acids for your PN when oral or enteral nutrition isn't possible or insufficient or contraindicated. It provides 10 calories per gram, and it is can be used for adults and pediatrics. Again, your contraindications are going to be any hypersensitivity to fish, egg, soybean, or peanut, and then hyperlipidemia, so triglycerides over 1,000. And this is a nice lipid for your patients that need a lot of calories because they're not growing or they're not able to tolerate their enteral nutrition. So you can see here that with your neonates and your kids less than 12, you can go all the way to 3 grams per kilo. And your 12 to 17-year-old and your adults can also go all the way to 2.5 grams per kilo. Again, the max infusion rate is listed on the bottom. It's the same as the soybean oil for pediatrics. It's 0.75 ml, and adults it's 0.5. Another option for these patients is going to be your fish oil-based lipid emulsion. This is a source of fatty acid for pediatric patients with parental nutrition associated cholestasis. And unfortunately, this is what a lot of our patients come to with us is PNAC because they've been on PN so long, it's not been managed properly. So this is something that can be used for the peds. Again, it's approved for peds, but not adults. Contraindications are going to be an allergy to fish, egg, and other ingredients, and the PI, as well as high triglycerides over 1,000. This is used when your D-Billy is 2 or higher. This can also be used for your patients that come to you on PN but have an allergy to soy, olive oil, palm oil, or coconut oil, or they have any other intolerance to another lipid. But it's important to know it's not used for prevention of PNAC. And this provides a little more at 11.2 calories per gram. So the dosing here for your peds, the initial dose is 1 gram per kilo, and the maximum dose is 1 gram per kilo. So you would just start them at this dose. So what do you need to look for your patients, no matter what lipid emulsion they're on? You want to monitor their serum triglycerides, their liver function tests, their bilirubin levels, as well as an essential fatty acid panel, especially if you're not giving them the 30 to 40% of total calories from fat. This is something that when you do the calculations and see their regimen, you want to make sure that they don't have EFAD or increase them to their appropriate dose. Fluid needs in these patients. For pediatrics, we usually use the holiday Seeger method, and you can see kind of small up there, but dependent on the size of the child, what to give them. There's a lot that comes into account when you factor in the fluid needs for a short bowel patient. But again, you want to make sure you're taking into account all their excess losses. So again, this is going to be if they have increased G-tube output, what comes out of their ostomy? Do they have their colon or not? Do they have their ilium or not? Any emesis, excess urine. So really taking into account every single thing that comes out of them so you can make sure that you meet their needs. Because a lot of times these patients will come in and just say they feel dehydrated. And when you start adding up all the losses, you're not giving them enough fluid. So additional fluid is required for maintenance when they're febrile, when they have increased activity, when they're dehydrated. A lot of our patients in the summertime are outside, so they need more fluid in the summertime. So just making sure you're thinking of those things with these patients. And then secondary conditions that would require less than maintenance would be ascites, any cardiac issues, fluid overload, and third spacing. And you will see some of this with your short bowel syndrome patients because they have other issues going on. So you might have a cardiac patient coming to you with heart failure, but they're short bowel with our pediatrics. So you're not unfortunately able to give them as much as they need, but just making sure that they are getting enough so they don't get dehydrated. Again, they're going to require higher fluid needs. So sometimes it can be as much as 1.2 times maintenance, 1.4 times, all the way up to 1.5 times maintenance. So same with the calories, you're going to give them almost 1.5 times or sometimes more. I have patients that need double their maintenance needs. And that's the only way they feel good. They're not dehydrated and their labs are normal. At the bottom, the acceptable ileostomy output range is listed, and typically the acceptable range for an ileostomy is going to be between 25 and 40 mLs per kilo per day. Your acceptable colostomy range is going to varies. So less than 200 mLs per kilo means they're tolerating well. If it's between 20 and 30, you want to hold. And then if it's over 30, you want to stop these. Oral rehydration solutions. This is something that once the patients transition to an oral diet and you've gotten them off their PN, hopefully you've gotten off the EN, but they still need something. This is where you're going to see with the patients that still have high ostomy output that you want to give them these oral rehydration solutions to replace their fluid loss. So they don't have to go back on any IVs. And it's important to note that some sports drinks, while yes, they might have electrolytes in them, they can increase output because they have higher sugar amounts and lower salt content. So that's not the primary. You don't want to tell them to just go out and buy like a shelf sports drink. You need to really look at what the sugar content is of it, because a lot of them are extremely high in sugar, and look at the salt content. This is also going to be required if they have less than 100 centimeters of duodenum. And then it, again, will help with sodium absorption. So again, some can be purchased over the counter. Again, you'll have to label read. You'll have to make sure you're not giving them a high sugar one. They can also be made at home, which is typically what we tell our patients to do. It's the easiest. You know what you're putting in it. You don't have to worry about too much sugar and them having diarrhea. So here is listed some of the different recipes that people use. Sports drinks combined with water and salt. Some people will use water and orange juice, especially if they need the potassium, salt, and baking soda. Grape juice or cranberry juice, again, looking at the sugar content of these, and water with salt. And then the World Health Organization, their recommendation is the water, salt, and sugar combination. So complementary solid foods, talking about infants, we've talked a lot about promoting oral intake with these, but what do you give them so you don't promote diarrhea or make their outputs higher? These foods should be gradually introduced at 4 to 6 months, corrected age, to stimulate their oral activity and to avoid their feeding aversion. It's important with these patients to restrict lactose if they do show intolerance to it. You want to restrict their simple sugars, as this can increase their output. So we say that, and you're like, what foods can you give them? It's usually we start with infant rice cereal, followed by meats and vegetables, and usually no fruit or juice, because the sugar content in that is going to be high and can increase their risk for diarrhea. This chart here is a nice chart because it kind of just gives you a general idea of what kind of solid foods you give for a short bowel syndrome patient and what breakdown of carbs, fat, and protein do you give them. So you can see it's listed with their colon is present versus if their colon is absent. You want to make sure that they're getting complex carbohydrates, not simple carbohydrates. That they're fat. For their colon present, you want to ensure that the essential fatty acids are met and they're getting medium and long chain triglycerides. Protein is going to be 20 to 30% of their total calorie intake, whether their colon is present or not. Fiber, you want to give them soluble fiber. And foods high in oxalate, you want to restrict if their colon is present. And then again, fluids, giving them oral rehydration solutions or hypotonic fluids, avoiding the hyperosmolar. If they have their colon. If their colon is absent, again, avoiding hyperosmolar and giving them an oral rehydration solution. Soluble fiber supplementation. This can be beneficial if they have all or most of their colon present. Conversion of soluble fiber to short chain fatty acids in the colon can cause a significant calorie reuptake by colonic cells. So your short chain fatty acids, they'll also stimulate sodium and water reabsorption. So that's this can aid in their fluid management, improve their feeding intolerance, so help with their diarrhea that you see in these patients. And your short chain fructo oligosaccharides are the preferred source. Soluble fiber supplementation. This can begin use at a developmentally appropriate age when the colon is present. And these are some examples of what you can give and how much. Of pectin, you can do 1 to 3% solution, or 1 teaspoon per 4 ounces of formula if you have a formula-fed child. Guar gum, Typically, we give 3 grams of soluble per 4 ounces of formula. And then green beans, which we'll touch on the next slide. So you hear green beans, it's been around forever. We've all like it. So why green beans? There was a retrospective cohort study done with 18 infants. They were given stage 2 green beans. They added a jar to 240 mLs of a 1 cal formula. The results for these patients showed that before the green beans, they had 12 liquid stools, 6 had loose stools, but then after the green beans, 10 had mushy to soft stools and 8 had formed stools. So it did show an improvement in these patients. These are some of the medications that are used. That could be a whole talk in it itself on medications in short bowel syndrome. But you'll see anti-motility agents used, anti-secretory agents, H2 blockers. Very important to give a multivitamin to these patients, whether you're putting it in a PN or they're able to take an oral multivitamin. Additional B12, depending on what's been resected and if they show malabsorption. Iron, vitamins A, D, E, and K, potassium, zinc, and then pancreatic enzymes are also seen with some of these patients. Deglutide is also something that's used in a lot of short bowel patients. This works by promoting mucosal growth and possibly restoring the gastric emptying and secretion. So GLP-2 is a naturally occurring hormone that plays a role in maintaining the structure and function, and it also helps facilitate absorption. So you will see this given to adult and pediatric patients to try to help their absorption. Probiotics, these are live microorganisms that have a beneficial health effect on the host. They may be of benefit with acute diarrhea disorders, and variable results have been shown with chronic diarrhea. You can see the ones here that have been found effective to treat severe recurrent C. diff diarrhea. We have patients that use them and swear by them. Some patients don't. It's just dependent on the patient and the type that they are taking. And then finally, I've included the vitamin and mineral lab monitoring for these patients. It's very hard to find anywhere how to monitor and what to monitor when it comes to your vitamins and minerals, but this is what we do. For our parental nutrition patients, you can see that their iron studies are every 1 to 3 months. And then we do all the trace elements and vitamins 1 month after, and then usually every 6 months after. Now, if they show low levels, which unfortunately, as we know, a lot of these patients malabsorb, we'll check them more frequently and repeating every 2 to 3 months until we can get those levels corrected. Once they're on enteral nutrition, you don't have to check them as frequently. For us, we'll still do iron studies every 6 to 12 months, but they're trace elements, and the vitamins, again, we'll usually do once a year, but if they start showing deficiency, we'll do it more frequently every 3 months until we can correct it. And like I had stated earlier, a lot of these patients, you'll start to see that they might not initially show deficiency, but once you wean them off PN and they're on their enteral feeds or their oral feeds, about 3 months or so after, you start seeing the deficiencies occur. So, learning assessment questions. What's the primary site for B12 absorption? B, correct. What's a complication of short bowel syndrome? All the above. I'm not tech savvy, so it doesn't have like a circle or a highlight to the correct answer. And then EN needs for short bowel patients may exceed 100% of the DRI. Are there any questions? No questions? Like the post-lunch talk where everyone's trying to stay awake? Okay, well then if there's no questions, thank y'all.